Hey students, it's Dr. Kessler and you are listening to the lecture for Chapter 13, Fluid and Electrolytes, Balance and Disturbance. It's quite a long chapter with a lot of information, so take breaks as you need to. This will probably be the longest lecture that you have from me. I couldn't really figure out a good way to break it up though. So your objectives, you should be able to differentiate between osmosis, diffusion, filtration, and active transport. You should be able to describe the roles of the kidneys, lungs, and endocrine glands in relating to the body's fluid composition and volume. Plan effective care of patients with fluid volume deficit, fluid volume excess, sodium deficit and excess, as well as potassium deficit and excess. Describe the causes, clinical manifestations, management, and nursing interventions for all the electrolyte imbalances. Explain the role of the kidneys, lungs, and chemical buffers have in maintaining acid-base balance, and compare metabolic acidosis with alkalosis as well as respiratory acidosis with respiratory alkalosis, as well as knowing the causes, clinical manifestations, diagnosis, and management. As far as electrolytes, we'll hit each one of the electrolytes individually later, but sodium is the main electrolyte, and the extracellular fluid and potassium and phosphate are the main electrolytes in the intracellular fluid. All right, so now we're going to move on to electrolyte imbalances, and those are the different electrolyte imbalances that we're going to cover. So with hyponatremia or low sodium, it is considered hyponatremia if the serum sodium is less than 135 milliequivalents per liter. It can be chronic or acute. It generally results from a water imbalance that causes the low sodium, not simply just having enough sodium with regular amounts of fluid in the body. Extracellular sodium concentration will decrease, and the body responds by pulling fluids into the cells to compensate and increase the proportion of ECF and sodium, and this causes the cells to swell. As a result, you can have increased intracranial pressure, which will lead to seizures, coma, and death if it is not treated. The severity of the symptoms will correlate to the severity of hyponatremia and how quickly it develops. As far as management, you want to try and figure out why they're having low sodium and then treat the symptoms. If you have a patient who's on lithium long-term, lithium can deplete the body of sodium. So check for lithium toxicity, and if they have a history, maybe they aren't currently on it, but they recently stopped it. You will replace their sodium, and they have tablets, or you can do it parenterally, but they like to do it orally if they can. These patients, you want them to eat and drink foods that have large amounts of sodium in them. They might have a water restriction, and that's because they have, usually your sodium's low because you have too much water. As far as assessment, you want to monitor their intake and output. You will do a daily weight. You will monitor their lab values, and then you want to monitor for central nervous system changes, cognition changes. Hypernatremia or high sodium is if the serum sodium is greater than 145 milliequivalents per liter. You can have increased urine-specific gravity as well because the kidneys are trying to compensate for the high sodium by conserving water. The only exception to this is diabetes insipidus, and then their urine is actually going to be pretty dilute. Hypernatremia can occur with fluid volume deficit. It also can occur with fluid volume excess, so hypo or hyper fluid volume, or it can also, you can have normal volume. It affects the young, it affects the old, it affects people who are or are not cognitively impaired. So you can basically see it with anyone. It can also be seen with people who are hyperventilating. If they have diarrhea, burn patients, you will see hypernatremia quite a bit. Sometimes diabetes insipidus. Again, remember, diabetes insipidus dilute urine, and then otherwise hypernatremia, you're going to have concentrated urine. Okay. The primary characteristic for hypernatremia is thirst. They can also be confused, they can be restless or agitated. As far as treatment, you want to lower the sodium level, but you want to do it slowly. And you can give them a hypotonic solution like D5 in water. That is a non-electrolyte solution, but it can be given. It's indicated when water is needed without the sodium replacement, which if you have someone who has hypernatremia, they don't need the sodium. You still can give a hypotonic solution like a half normal saline, and that will help as well. If you have a patient who has enteral feedings, you want to make sure that they're getting enough free water. The higher the osmolality of the food, the more free water they're going to need. And that will help to offset the sodium that's in the enteral feeding. You want to educate them. You can give them different medications. You want to assess for any abnormal loss of water. You also want to assess and make sure that they're consuming enough. So they should have an adequate amount of water intake. And here's a quick snapshot of if your sodium is high, if your sodium is low, what you would expect to see. Now we're going to talk about potassium. So hypokalemia is low potassium, and that's when your potassium is less than 3.5 milliequivalents per liter. It can occur with normal potassium levels when alkalosis is present. We'll talk about that in a little bit. The kidneys hold the majority of the responsibility in keeping potassium balanced. So if you have an impaired renal system, that will affect your potassium levels because they're not able to function to keep the potassium levels balanced. Hypokalemia can also occur if you have significant GI fluid loss. So after bowel surgery, especially if they're connected to NG suction, the fluids are lost through the GI tract, and that can cause hypokalemia. The patient will have diluted urine if their potassium is low, as well as other symptoms, which you're going to see on the slide. Metabolic acidosis could be the cause of having the low potassium, and we'll talk about acidosis and alkalosis in a little bit. Very, very important because calcium affects the muscles. You want to make sure you get them on some kind of continuous telemetry monitoring, and you want to do an ECG. If the potassium is really low and you look at their EGC or ECG, they'll have a flat or inverted T wave. Their ST segment will be depressed, and then they can have an elevated U wave as well. As far as management of hypokalemia, potassium replacement. Oral supplements are preferred if you want, or just taking, sometimes you can't take in enough potassium through dietary changes quick enough, so you can take oral replacement. You can also do IV, parenteral replacement, and it needs to be slow if you do that. Obviously, you're going to monitor for ECG changes. You're going to monitor their ABGs because there could be an acid-base imbalance that's causing the hypokalemia. Look for early signs and symptoms, and don't give, if you do have orders for potassium, make sure that they are actually voiding, because if they have kidney damage, and that's why their potassium levels are off, and you start giving them potassium and they're not able to get rid of the excess whenever their body has enough, then they can have hyperkalemia, and you're causing another problem. You don't want to do that. Hyperkalemia is a potassium greater than 5.0 milliequivalents per liter. But hyperkalemia is seen more in older adults. It can lead to cardiac arrest. It is less common than hypokalemia, and it's mainly seen in patients who have untreated kidney injury or an untreated infection. And ECG, the earliest changes that you will see on a patient who has high potassium are peaked narrow T waves. They also will have the ST segment depression, shortened QR intervals as well, but they do have those peak narrow T waves. If you do not treat the patient at this point and their potassium levels continue to rise, the PR interval will become prolonged, followed by disappearance of the P wave completely. If you still ignore that and decide not to do anything about it, then there will be decomposition and widening of the QRS complex. Then you'll get ventricular dysrhythmias, which will lead to cardiac arrest. So hyperkalemia is definitely something that needs to be addressed, and it needs to be treated right away. As far as the nurse, you're going to monitor the ECG. They should be on telemetry as well, so that they have continuous monitoring. Look at their labs, look at their potassium level, look at their kidney function, monitor intake and output. Make sure you get an apical pulse. Limit their dietary potassium. Make sure you do dietary teaching. A lot of times patients who have cardiac history are told that they cannot have table salt and they need to look at supplements. One of the supplements for salt is potassium chloride. And then if they use that a lot, then they'll have high potassium. So whenever you're educating a patient who is on a low sodium diet, make sure that they understand that getting just any kind of substitute, if it's a potassium chloride substitute, and they're using it just like they use their salt, then they're going to have hyperkalemia. Okay. If you have higher potassium, they'll give Electrolyte, and that will make them have loose stools, and they will just have a lot of loose stools. It really cleans them out well, and it pulls that potassium out through their GI tract, their bowel. If it is something that is an urgent emergent situation, they can give calcium gluconate, sodium bicarb. They also can give insulin, hypertonic dextrose, beta antagonists, and they can even do dialysis. All of that needs to be done except for the bicarb, calcium gluconate. Those are a big vial push, but the insulin, the dextrose, that would be done through an infusion pump. Okay. And here's high and low as far as the potassium goes. And then we have calcium. So if you have low calcium, hypocalcemia, that's less than 8.6 milligrams per deciliter. It's controlled by the parathyroid hormone and calcitonin. It is absorbed from foods high in calcium through the GI tract. It is regulated by the parathyroid gland. So the parathyroid hormone is released when more calcium is needed from the body to be absorbed. If there's too much calcium in the body, then calcitonin is released. And then you have the two cardinal signs of a low calcium is you have Chavasik sign, which is twitching of the facial muscle. So you're going to take your finger, you lightly tap over the facial nerve in front of their ear, and their facial muscle will start to twitch. You also have Trousseau's sign. So you're going to take a blood pressure cuff, find out what their normal systolic is, go 20 millimeters of mercury above that, and in 2 to 5 minutes, you should see carpal spasms. So there's Trousseau's sign. As far as management for hypocalcemia, you can give IV calcium chloride. It is very irritating to the vein. It can be caustic and it can cause Extravasation if it infiltrates. So if it leaks around the IV site or the IV catheter, that's called an infiltration because the fluid's seeping out. Extravasation, it eats away at the tissue, the muscle, the vein. You can also give oral vitamin D therapy, and that will increase the absorption of calcium because vitamin D will help increase calcium absorption in the GI tract. You can also give calcium acetate, calcium carbonate, or aluminum hydroxide antacids. Those are all over the counter and they will lower the phosphorus. And if you remember, when phosphorus goes down, calcium goes up. So they're like a seesaw. If one's up, the other's down. And that lowering the phosphorus will increase the calcium absorption as well. You want them to eat foods high in calcium. And so milk products, green leafy vegetables, canned salmon, canned sardines, fresh oysters, those types of things. They can also do calcium supplements that needs to be taken with vitamin D, and there are some that are better than others. Hypercalcemia is high calcium. That's greater than 10.2 milligrams per deciliter. It requires immediate treatment or death will ensue. It has a 50% mortality rate whenever you have high calcium levels. The high calcium levels will suppress activity at the myoneural junction, which reduces neuromuscular excitability. This will lead to decreased tone in smooth and striated muscles, causing the symptoms that you will have. Okay. You do not want to have smooth muscle decreased activity because that will affect your heart. Okay. On an ECG for someone who has high calcium, you can see PVCs, preventricular contractions, different types of heart blocks. They'll have a shortening of the QT interval and the ST segment, and the PR interval will be prolonged. As far as management, you can give normal saline IV or 0.9% sodium chloride, and this will dilute the serum calcium level. It will increase voiding, which will increase calcium excretion. You can also give IV phosphate to cause a drop in calcium because you're increasing the phosphorus, which will in turn decrease calcium. Furosemide, which is a diuretic, can also be given with the normal saline, and that's so that the kidneys can excrete the calcium. You can also give calcitonin, and that will inhibit calcium reabsorption. So there are many different things you can do. And then here's high and low calcium if you're a visual person. I like nursing camp. They have a ton of stuff. So if you're looking for extra resources, go to nursingcamp.com. They have not actually a whole lot of stuff that's free, but they do have different packages, and they give you quite a bit of information and books and access to online resources. Okay, low magnesium. Hypomagnesemia is a magnesium less than 1.3 milligrams per deciliter. Magnesium is an intracellular cation, and it causes a sedative effect at the neuromuscular junction, and it can increase the stimulus threshold in nerve fibers. It acts peripherally to produce vasodilation and decrease peripheral resistance. It's mainly absorbed in the distal end of the small bowel. If you have low magnesium, your ECG will show prolonged QRS segment, depressed ST segment. You can see PVCs, SVT, supraventricular contraction, or torsades de pointes, and then VFib, ventricular fibrillation. So we definitely don't want low magnesium levels. It's generally associated with low potassium and low calcium as well. Okay. If you have low magnesium, then they'll give magnesium sulfate. Monitor vital signs because you don't want to bump that magnesium up there too high. Monitor urine output. You can encourage them to have a diet high in magnesium or higher in magnesium. And that would include green leafy vegetables, nuts, seeds, legumes, whole grains, seafood, peanut butter, and cocoa. You want to make sure you maintain seizure precautions because it does affect the neural pathways, and if it suppresses them, you can have seizures. Hypermagnesemia is a magnesium higher than 3.0 milligrams per deciliter, and its most common cause is kidney injury. So if you see someone with elevated magnesium, look at their kidneys and see what their kidney function is doing. Look back at the history, see if they have any chronic kidney disease. Maybe it's an acute injury. The ECG for someone with high magnesium will have prolonged PR intervals. Their T waves will be tall with a widened QRS, complex prolonged QT interval, and they can have an atrioventricular block if you do a 12 lead. Okay. They're going to have diminished deep tendon reflexes. They're going to be drowsy, weak, can have suppressed respirations. They will go into cardiac arrest. As far as management, give them calcium gluconate if it is an emergency situation, and you're going to see that on all the crash carts. You can perform hemodialysis to pull that excess magnesium out. You just need to make sure the dialysate is magnesium free. So if you want to be a dialysis nurse, that's something that you need to know. You can give loop diuretics. You can give them sodium chloride, the 0.9%, which is just normal saline. You can also give lactated ringers. Okay. Obviously, if their magnesium is high, you want to avoid medications that have magnesium in them. And also teach about medications that are over the counter that do contain magnesium. And magnesium is being prescribed for patients, or there's magnesium in different herbal remedies for migraines, for people who have restless leg syndrome, or if they have anxiety, trouble sleeping, they'll say to take magnesium. So you just need to make sure your patients are aware if they're not filtering it out. Observe for deep tendon reflexes, and then also changes in level of consciousness. And then here is the visual for high and low. And I'll make sure you get a copy of the handout, or at least the nursing camp things. All right, hypophosphatemia is low phosphorus, and it's phosphorus less than 2.5 milligrams per deciliter. Phosphorus is the primary anion in intracellular fluid. Most of it is located in the bones and the teeth. You must be careful in treating those who are malnourished because returning nutrients and calories too quickly can lead to hypophosphatemia. That's one of the biggest things that you watch for. If you have someone who has failure to thrive, someone who is malnourished, who comes in from being homeless for an extended period of time, or you have those people who, there was a kid who fell in the well, or the miners that were stuck for almost a week without any type of food or nutrients. Resuming the nutrients too quickly will drop their phosphate level. The nurse needs to identify clients who are at risk and monitor them. Malnourished clients, especially if they're receiving parenteral nutrition, which is TPN, if the calories are off or it started too aggressively, you will see that phosphate level drop, and it will drop pretty fast. Best thing to do is prevent. If it is low, you can do IV phosphorus. You can also do oral. Okay. If it's high, you want them, it's anything level higher than 4.5 milligrams per deciliter as far as the phosphate is concerned. Generally, you see it with people who have kidney injury or if they're consuming too much phosphorus or too much vitamin D. And what you want to do is make sure that they avoid foods high in phosphorus. So they need to avoid hard cheeses, cream, nuts, meats, whole grains, dried fruits, dried vegetables, sardines. That keeps coming up, and I am not a sardine fan, but I guess some people are. Sweetbreads, and then foods that are made with milk as well. And here's the hypo and hyperphosphatemia if you are a visual person. And then we have chloride. Chloride is a major anion in the extracellular fluid. It's produced in the stomach and it's excreted out through the kidneys. So hypochloremia, you have a serum less than 97 milliequivalents per liter. There are many different causes, and it does work closely with sodium. So if you notice that the sodium is low, your chloride will most likely be low as well. Okay. The patients become irritable, they're agitated. You want to give them normal saline or half normal saline as a medical management, and that will, it's sodium chloride, so you will be giving them sodium plus chloride. Okay. Avoid free water because that can further dilute the plasma. High chloride foods, you can teach them about that. If their chloride is too high, which is a level that's more than 107 milliequivalents per liter, generally you see this if you're giving them too much sodium chloride, which is why you want to only give the normal saline or sodium chloride, it's the same thing, until they're normotensive if they're hypovolemic, and then switch over because you don't want to cause more problems. You can also see it with respiratory alkalosis or metabolic acidosis. We'll talk about that. Okay. These patients are weak. They have deep, rapid respirations. They have lethargy. They can have a high blood pressure, high heart rate, and then they'll also be confused. And there's that one. Something to be aware of, hyperchloremia can have the same symptoms as metabolic acidosis. So sometimes people do not catch the high chloride because the patient will present with the same exact symptoms as metabolic acidosis. So they'll